Good afternoon, everyone. I guess by now everyone knows me. So I'm going to present a couple of cases. Actually, I think we may not get past the first case because the first case is interesting and it's a couple of different differential diagnoses that we should be all aware of while evaluating such an entity. So I thought areas that we should focus on are areas that we are weak at or we don't see as commonly. If we do get enough time, then we'll go over one other area that I think we're weak in, which is evaluating wall motion abnormalities. So I tried my best to make everything super simple so that everyone understands, and my hope is that by the end of this session, everyone understands the differentials for this particular case. So this is a 67-year-old retired pilot who was previously in good health. He presented to the hospital with shortness of breath and complaints of chest pain. His only past medical history was that of hypertension, hyperlipidemia, and he had an abnormal stress test several years ago with coronary angiography that was not abnormal, and he did not have any further stents or needed any kind of bypass surgeries. At the time that he presented to the hospital, he was NH5 class 3, and he had a typical chest pain that radiated to his arm and jaw. He was diagnosed to have non-ST elevation MI. His peak troponin at the time was 2.7, and he concurrently was in atrial fibrillation. This time when he underwent a coronary angiography that revealed a large aneurysm in the ostial left circumflex, beyond which the artery was completely occluded. The LAD and right coronary arteries both had minimal disease. This is his angiogram. As you can see, the right is pretty clear. This panel B shows the right coronary artery for those of you who don't know how to read angiograms. This here shows an aneurysmal segment in the circumflex, and then beyond this, the artery doesn't really have any flow. But this is the LAD, and that looks like there is a reasonable flow in the left anterior descending artery. So he underwent an echocardiogram. He was transferred here, and I guess I'm hiding some of this information as to why he was transferred so that we can come to a differential diagnosis looking at these this echo. So basically, just for the fellows, there are two abnormal findings. If you all could locate them or shout out the answers. I'm going to go phase by phase into this a peristernal lung, and if any of the techs note anything that they think is abnormal, please don't be shy. So I'm going to leave this on for a minute. Anything? Any comments? Bashar? Santi, Bashar, John, Jeff? Okay.
Well, we all know. Yeah.
I don't know, there's something popping in and out of the apex. I can't tell on the upper right.
Yeah, one of the of abnormalities is the inferior wall doesn't move very well, and I have a Definity image. I can show you that. Yeah, that's a 4-chamber, a 2-chamber view. Here you can clearly see that the inferior wall doesn't come in as nicely. This is a 3-chamber view here too. So the infralateral walls seem to not move very nicely. So one other abnormality, if was
So kind of he was making those about the apex.
Yeah.
The apex, he's talking about something. So
Uh,
they based on the contrast.
The contrast,
yeah. Yeah.
Right. So we based that.
Mhm.
This is on that.
Right. So maybe I'll play the one that I think are a little bit more suspicious, and redirect your attention to the left atrium. Does
Is there, I mean,
it's okay. Just say whatever you think it is.
is there like the leaf that looks in and out the left
Uh,
The uniform of them?
So you're right, there is a leaflet abnormality.
Mhm.
So,
Is it prolapsing or is it like flared or what is it?
You're right, the mitral valve is not normal, and but it wasn't completely clear on this transthoracic echo. But there's one more abnormality.
can you play the long, and we can look at the leaflets a little bit. So if anything, what you see on that one is that the posterior leaflet looks fixed or tethered. See how it's not moving? But the anterior leaflet is moving fine, and that's kind of what you see on the lower tibial posterior leaflet that's really moved.
Anything in the left atrium? Any takers on the left
Now,
atrium?
move this bottom, yeah, this one
Yeah.
right here. What do you guys see down there on in the left atrium sides down here? Moving.
Something moving. I thought I thought that's a leaflet. What is it? Like fog or like a mass?
Do you see that, yeah, do you see that thin little,
Yeah.
what could that be? And you also see it over
Mixed
here,
over.
you also see it over here,
You see it here.
yes, you see it on the bottom too.
So I'll just point at it. Really, I'm hooked, so I have to move with this. But I guess
Yeah.
this
What is it?
structure.
Myxoma?
So what do you think it could be? Any other?
Like a core tritracheatum would typically be like, I guess, the other direction. Yeah, same thing as the valve.
Any of the sonographers want to take what this would be? Anyone if you've seen this?
So I guess maybe
Yeah.
we have no takers on what that is.
Mhm.
I guess the question is what would you do to further evaluate that? They want some more pictures.
What? This is what I got. It was a really nasty echo. Okay, so then just let me say one more thing, that the color didn't really show it very well here, but there's also a suspicion for mitral regurgitation here. So I mean, the question is, what would you do next? So we see that the EF is rather preserved. There's maybe EF of 68, 64 with inferior wall hypokinesis. You see this unusual cystic structure, which is visualized if you anatomically posterior and lateral to the left atrium. So, and in the interim, the patient develops recurrent pulmonary edema. On exam, he has a systolic murmur, and then there is suspicion for mitral regurgitation, which is significant. What would be your next step? Now, you have two questions to answer. One is, how bad is the mitral regurgitation? The second question you have is, what is this unusual cystic structure that you're seeing?
CMRT,
Okay, so
functional.
mhm. Nick, do you have any take on the cystic structure, since you're the most, and Eric, since you're both
be
advanced?
I have to be honest, one, I have glasses because I can't see four tiny little
Okay.
buildings.
That's my bad. But there are too many images, so I didn't want to put it. Okay, that's my bad. Okay. Okay, sorry, that's my bad. Okay. So the patient did get TEE, and on the TEE, as Bashar, you were pointed out regarding the mitral valve, there's a tethered posterior leaflet, and you see a significant degree of mitral regurgitation and was severe. And then again, you see the cystic structure that appears again posterior to the left atrium. So now that we see it a little bit clearer, any differentials that you guys could throw at me as to what this cystic structure could be, which has a very close relation. Aneurysm of the,
Third aneurysm.
okay.
And that structure is like, yeah, that structure, you're right. There's a scale up there, and that first number you see is a 5.
Mhm.
So that structure is at least 3 centimeters.
Mhm.
Is it a persistent left-sided SVC?
Yeah, that's a good differential. So that's it could lead to coronary sinus being dilated. So that's what the thought was, that this is probably a dilated coronary sinus. But the question now is that how do we prove it, that it is truly a dilated coronary sinus? So I mean, then I
Well,
mean,
for example, you wouldn't expect to see, it looks like there's something inside of it, right?
yeah,
You wouldn't expect to see that if it's just persistent left SVC.
exactly.
With dilated
Yeah.
coronary sinus. Do they have flow?
Wouldn't you see some color?
So
You're right, you expect to see.
so that those color images were done, and there was no apparent direct flow into the structure. I know there was a lot of images, but I knew this question would come up, and there was no direct flow or direct connection seen between any of the structures that they visualized, and causing any color flow directly into the presumably the coronary sinus. But you're right, absolutely. There's a echogenic material inside it, which is concerning.
There was a thought that it could be a peripheral cyst, and I know that they went back and they got more images trying to figure out whether or not that was a peripheral cyst. Now, that's not the typical place for a peripheral cyst, but they can be anywhere. I mean, I think in the end, we decided basically that the echo was just not enough to tell us exactly what the structure was.
Right.
I saw the 3 other images, CT, MRI, everything else that happened. I was just curious, could it be?
No, that's definitely on the differential.
Yeah.
Absolutely.
Yeah. So at this point, what the team taking care of the patient agreed on was perhaps this is a dilated coronary sinus. And now the next question is, what are a differential diagnosis for dilated coronary sinus? And the reason why I bring it up is because I think when a case with such a dilated coronary sinus comes into the lab, not every one of us will see that. And it's, I think, important to understand what exactly would cause a dilated coronary sinus. So any takers, on Josh mentioned one, that was the persistent SVC. Any other differential diagnosis for dilated coronary sinus?
Anomalous pulmonary vein return.
Yeah, that's one.
Coronary, arteriovenous fistula with the coronary.
Yep, that's a third one.
High right atrial pressure.
Yep,
The most common.
that's. Did you know this case? I'm gonna.
Study for endoboard.
So I guess, Jeff, you nailed it. This is a persistence of the left superior vena cava, any cause of elevated right atrial pressure, partial anomalous pulmonary venous drainage, and coronary AV fistula. And the one that you missed, don't get 100%, is the unroofed coronary sinus with shunt flow between the left atrium and the coronary sinus. Now I'm going to go over how we decided which one is it or which one it was not. Because now we have 5 diagnoses, and we don't know this person who has severe mitral regurgitation and has a circumflex that is occluded. He needs to go to surgery for the ischemic mitral valve. But does he need any other surgical procedure, which is a very important question to answer at this point in time. So how do we go about this? So I think it's important to understand what does a persistence of left SVC really mean? That's one question for me that I thought is important to answer. And then, does anyone know how in echo we diagnose persistence of left SVC? What do we do? That's exactly right. So we do saline in the left arm and the right. And then what do you expect in the saline if you have a persistence of left SVC?
Choose the coronary sinus first, and then enter into the RV.
That's absolutely right. But what was, I saw this case and we were trying to give the injection. I didn't understand why it would go first to the coronary sinus versus other structures. So I'm going to go a little bit over what happens when, on an embryological point of view, and what exactly where the coronary sinus is located, what exactly to expect. So we all kind of know by now the anatomy of the coronary sinus. So the coronary sinus is located in the posterior portion of the coronary sulcus. It will light up in just a bit, that yellow structure. And it's on the posterior surface of the heart. It empties directly blood from the right atrium near the junction of the posterior interventricular sulcus. And it's located between the IVC and the tricuspid valve. It empties into the atrial ostium, where it can also have a valve. Sometimes it has a valve, and that valve is called the DeBakey valve. And it drains basically blood from all these veins that you can see from most of the epicardial ventricular veins, from the oblique vein of the left atrium, the greater cardiac veins, and the posterior vein of the left ventricle. So these veins all make a confluence, which is basically the coronary sinus, and they drain blood here, as you can see in this structure. And the general length of a coronary sinus in an adult is between 15 to 65 millimeters. Why or what is left-sided SVC? So what happens is that during development of the right atrium, there is a sinoatrial chamber that basically differentiates into sinus venosus and the atrial chamber. So basically, you have this kind of like a cup that has two veins or four veins coming into it. And basically, these are the anterior cardinal veins. This one persists through the rest of your lifetime. It forms basically the SVC, the innominate vein. But the vein here, basically, it degenerates. And it loses its connection between the coronary sinus and this portion here on the left side. So when you kind of, if in a normal person, you would only have this SVC, but there's no left-sided SVC. Basically, there should be no connection between the veins here and the coronary sinus here. So now, Bashar, I've given you this information. If I were to give an IV saline injection from the right side, what would you expect? Where would the blood show up first on your echocardiogram? Just look at this structure and tell me where exactly you would see the contrast to show up first.
The SVC, the right side is
So SVC and then where?
the coronary sinus.
So the coronary sinus is here, right? So SVC, RA, right ventricle, and then right atrium, right ventricle, and so on and so forth, right? But what about a left-sided injection?
That would go there.
Then what, if there is persistence of this structure here, where will it go first? It will go to the coronary sinus first, and then it will go to the right atrium subsequently after that. Like, I don't know what your name is. You nailed it. Like you explained to us that basically it goes into the coronary sinus first when there is persistence of the left SVC. So I think this concept is important to understand.
The key thing there is usually the left innominate vein is not present.
Okay.
Right?
Yeah.
And it just drains
It's the SVC, it's the left side of the SVC, yeah.
Into the coronary sinus.
into the coronary sinus.
Yeah. So basically, this is kind of like a background and what to expect when you're doing an echocardiogram. This is not our case, but our images were not as great. But I wanted to like go over a case where there is persistence. So you have basically you do this in a parasternal long. Typically, the coronary sinus is best seen in this view, which was not the case in our patient because our parasternal long was not the greatest. We saw it more in the two-chamber view. So basically, we see this structure here. And then you do a contrast injection on the left side, and you see the coronary sinus opacify, right? You see that opacify first, and then a few minutes later, you see the pacification of the right side. And then this is very nicely illustrated in this M mode, and Rob's not here, or he would have loved this M mode, where you see that there is opacification earlier here, and then there is subsequent opacification here.
We can actually show this better on a modified four-chamber.
Mm-hmm.
So if you just, the technicians know this because we teach them to do it this way. So it's a modified four-chamber where it's just rotated a little bit.
Mm-hmm.
So you pick out part of the left atrium, part of the right atrium, and the coronary sinus go in between.
Okay.
And you literally can see the contrast going across that long tubular coronary sinus because you can now pick it up
Mm-hmm.
first before it dumps into the
Yeah,
right
Dr.
atrium.
Parma showed to me one case when I was trying to struggle to get that, how it's traveled,
Mhm.
right atrium and then the right ventricle.
Right.
Yeah.
And then we struggled in this case because we gave the injection first and we were all wrong, and we gave it wrong, and then we had to do it again. So that's why it's wrong. So anyhow, this patient did not have this contrast feature. So this persistence of left SVC is out of the picture. Now, any cause of right atrial pressure? Now, right atrial pressure is easy, right? This is that patient's.
How did you give the injection?
So we did the left and the right, but in the beginning, I mean, we didn't time it appropriately. We were not in the right view, so we really couldn't see where it opacified first. And our images were not the greatest, so we couldn't really see the coronary sinus very well on those images. But then we had Muaz's help, and he went and he did it. So after that injection, we really didn't see any opacification of the coronary sinus. And still we were, this cystic structure is still in question, so we didn't see any opacification there. So any cause of elevated right atrial pressure, so I'm going to, Bashar, what is the right atrial pressure in this patient?
Sorry?
Huh?
Yeah, that's correct. Probably, I think maybe 5 to 10.
Yeah, so this is not elevated right atrial pressure, right? So, and even though when we see, right atrial pressure, many times we see a right atrial pressure that's in the 20s, 25 range. I've not seen dilated coronary sinus with that. So I don't know what kind of right atrial pressure actually leads to. Maybe it's a chronicity of it, that you have persistently elevated right atrial pressure, but so far I have yet to see a dilated coronary sinus just because of elevated right atrial pressure. Now, the third differential is the unroofed coronary sinus with shunt flow between the left atrium and the coronary sinus. So my first question to myself was, what is the roof of the coronary sinus? Where is the roof of the coronary sinus? Where is the roof? Anyone, any takers on this?
Is it intervention?
At the end of the annulus of the mitral valve.
So you,
Because the coronary sinus travels, but it's not underneath the mitral valve, so then the roof should be right underneath that.
so I guess you're kind of close. So the coronary sinus roof is actually in the left atrium. So if you ever have an unroofed coronary sinus, you see basically this arrow. Can everyone see this little arrow here? That there is a connection between the coronary sinus and the left atrium. This is an unroofed coronary sinus, and when you basically do a left upper extremity agitated saline injection, you see prompt filling of not only the coronary sinus but also of the left atrium. So basically both structures fill in, and then you see like a flow across the left and the right.
So how would you diagnose it if there's not a persistent left-sided SVC?
How would you diagnose it if this is not a?
Because the only way that bubble test will work is if there's a left-sided SVC, right?
No, because if this here, you just need a shunt. There's an opening between the coronary sinus and the left atrium. So remember, in this, in the persistence of left SVC, it was more like you had saline that showed up here, and then it showed up in the right side. But there was no connection between this and the left atrium. Here, we're saying that that you will see it in the left atrium as well. That's what differentiates it from.
Yeah, but if there's no way bubbles are getting into the coronary sinus unless there's a persistent left-sided SVC.
No, I think you have to give the agitated saline in the right column, not the left, right?
Yeah, but
Well, then we'll go
from
to
the coronary
coronary
sinus to the
sinus.
right atrium, it doesn't go back.
Because the coronary sinus normally is left-sided
It's just right.
flow, so it's only when there's this anomalous, or this persistent left
Which is the
SVC.
most common, which is your type 1 unroofed coronary sinus. The most common one is the one with the persistent left-sided superior vena cava. So that's your type 1, but you're right, you're not gonna get your type 2 or your 3 or your 4 by it, but you're gonna get the most common one.
Yeah. Okay.
The others, yeah, otherwise,
Oh, you
otherwise
get
it gets tricky. Otherwise you're just looking, trying to find color flow, for the others, you're trying to see it by color flow, you're trying to, you're still gonna get saline contrast, but you're not gonna get flow in that, necessarily flow in there unless the right atrial pressure is really, really high. Maybe you get it back up your coronary sinus and then crossed it to your left atrium if your right atrial pressure was much higher than your left atrial pressure.
Yeah. So I mean, before we do all of that, we have to kind of do some basic work. So basically, I guess what I was trying to get at is that none of that was the case, and this is what our saline injection showed. Now you'll see some color flow come up here. There is some, what we noticed was there were some bubbles that go across onto the left side. There's a right-left shunt, which we thought could be because of a small PFO, but we don't see like a huge color flow or saline go across, which could fit in with any of the other diagnoses. And this is the one that we did in the parasternal long, and you don't see the coronary sinus fill up, or you don't see any filling here in this structure here whatsoever. So basically, those above mentioned diagnoses were all kind of still in the air, but we didn't think that was the direction that we were heading into. So basically, we've kind of ruled out persistence of left SVC, right atrial pressure being elevated, and then the unroofed coronary sinus with shunt flow. Now, the next one that Josh mentioned was partial anomalous pulmonary venous drainage, and then there is one other diagnosis that is coronary AV fistula. So, what would be the next best step in this situation? So, how would you go about diagnosing partial anomalous pulmonary venous drainage? Let's assume we're not in the world where there's MRI. Not every hospital has MRI. We're very lucky to have MRI. But what would be the next step? Something that you do every day. So, right, you could do a TE, right? So just this is a good paper for everybody to read, I think, because they talk about the techniques they can use to identify the pulmonary veins. So if you're trying to find out the right side pulmonary veins, then you do 70 degrees medial flexion and rotate the shaft rightwards. And then if you're trying to look for the left sided pulmonary veins, then you do 110 degrees lateral flexion and rotate the shaft towards the left side. This is kind of the bane of my existence. I have a difficulty finding pulmonary veins most of the times, and always the attendings take over. But I think this might be a helpful little tip to figure out. And then what you see is at the level of the PA, you see this the right lower, right upper bifurcate and form a Y, and similarly here you see the left upper and the left lower that at the level of the PA though. That's kind of high. We usually go in, and there are several other views that many of us have seen where we're able to obtain the pulmonary veins. So there is obviously different types, because they can drain into various structures, but there is one where there's anomalous pulmonary venous connection to the coronary sinus. And then what happens is here you see the left upper pulmonary vein, and that drains into the coronary sinus. You see blood flowing here. Anatomically, it's kind of like this, where the left upper drains into the coronary sinus. So this also, we didn't do the TE ourselves. This was an outside TE, but according to them, they didn't see any connection between any of the pulmonary veins and the coronary sinus. And I've reviewed their TEs, but they haven't, they didn't illustrate that. So then.
What if you have a right middle pulmonary vein and then a right lower vein that connects to the IVC?
So I guess what you should do technically is look at all the pulmonary veins and make sure there's and look at the coronary sinus and kind of trace it all along and make sure there's no drainage from anywhere there.
Right, with the TE, it's hard to.
But the point is,
Yeah.
you
Yeah.
can't go back.
Right.
Yeah.
So if you're really suspicious of it, a TE is not going to be satisfied.
No, that's absolutely right. But I'm just trying to make a teaching point here that this is how
I
it.
think the issue is if you don't have access to cardiac MRI, most places have CT.
Yeah.
Right, and a CT scan can also help you.
Yeah.
'Cause it's important really to not just look at how many veins there are attacking the left atrium, but follow the veins back to see
Yeah.
where they go.
Yeah.
Because you can oftentimes have accessory veins.
Yeah, and
You
that's
can
the.
see four,
Yeah.
But there's another big one that you
Yeah.
don't see.
And that's exactly a great point, because sometimes when we don't see a vein, in TE we can only see the veins that actually drain, but if there is absence of one which drains somewhere else, we won't be able to see that vein. And it may have like anomalous drainage. Like one of Dr. Lin's case where we were able to find only 3 veins, the 4th one was actually by MRI and CT was draining into the dominant vein, I believe. So we couldn't find the 4th vein. That's the limit of the information you can give out of a TE. But
I think
in
if you're missing one, it's fine. The issue is sometimes you could see 4,
yeah.
or there could be a 5th one.
Yeah.
Right.
Yeah.
But you're not.
Exactly.
You don't even know that you're missing.
Yeah,
you know,
yeah.
so.
Yeah, that's a good point too. So in this case, again, I just wanted to illustrate that there is that you can have a dilated coronary sinus because of anomalous venous drainage into the coronary sinus, and you can try to look for it by TE by tracing the coronary sinus and seeing if there is any drainage directly into the coronary sinus. Yeah, and that was the other reason why the TE was basically performed. So then this patient, of course, he was brought to Methodist Hospital for the evaluation of mitral regurgitation, and then before surgery, we were trying to figure out what this cystic structure was, and then basically, as you can see by this CMR, Dr. Shah, if you want to comment on this, but I don't have a lot of images, but I wanted to show that there was like infarct area, and also there was they saw that the mitral leaflet was fixed.
Let me just ask the fellows, what's that black
Here.
Yeah, right there. What's this whole thing here? Right? Because remember, what an infarct should originate where? Subindocardial work outward,
Mhm.
right? So is this really an infarct? Or is it
Hmm.
something else? Something else causing hypertension.
Is it like a layered thrombus?
Okay, so your differential here is this could be a layered thrombus. What else could it be? When you have this, there's two things in the differential here, Nick.
Microvascular obstruction.
Right. So it's possible if you have microvascular obstruction, there's an area in the center of the infarct that doesn't take a contrast initially. And so both a layered thrombus or microvascular obstruction can both give you this.
Mhm.
And then how do you differentiate between the two? A later
Delayed
so
phase.
there's repeat imaging again 10
Mhm.
minutes later, and if it's microvascular obstruction, it will eventually start to fill in with contrast.
Mhm.
Whereas if it's a thrombus, it shouldn't fill in with contrast.
Okay.
So this is probably an infarct. Yeah.
Okay. So, and basically, the MRI was findings were consistent with a corny sinus that was completely obstructed. There was no flow. There was a
Do you have
thrombus.
a contrast view of that two-chamber? Because that what you have there is just a single.
Yeah, I don't
So,
have that.
I mean, to kind of prove it to yourself, you want to see that there's no contrast uptake
Right.
in that area to say there's thrombus.
Okay. So you want. Okay. So you want one phase and then a delayed phase to make sure that there is no
Or just
contrast.
a contrast phase. Because what you have there is just a single.
Single phase,
like a
okay.
non-contrast
Okay.
image.
Okay. All right. So yeah, that makes sense. So basically, it was consistent with the thrombus, and now the question was, how do we fit all of this in one clinical picture, right? And what information is missing? Because now we ruled out by a more conclusive diagnosis by doing an MRI that none of the other abnormalities that we had stated earlier were present in this patient. And this was all a dilated coronary sinus with thrombosis in it. But why would his coronary sinus become thrombosed like this? And what is the piece of information that's missing? Now you have just kind of like going back on the case. This is a gentleman who had a recent non-ST elevation MI, now has ischemic MR. His circumflex is completely occluded. And then he has a coronary sinus that is thrombosed. So remember, there was one differential that Jeff mentioned.
Because of his third aneurysm, maybe these two.
Exactly. So then we did a CT scan as well, and basically, I think what was really helpful was also going back to the patient's history and trying to, figure out what he knew about his history, because we knew that he had a cath done many, many years ago, and if there was truly an AV fistula, that would have been either told to him or the physicians knew. So basically, when we kind of reviewed his records, he had had his first cath here 15 years ago. We couldn't pull up the exact images, but he actually had an AV fistula at the time. And on the CT scan, you could see that not only was his coronary sinus completely thrombosed, and there was also the left circumflex that was also completely thrombosed. So the hypothesis here was that either his coronary sinus first thrombosed from whatever reason spontaneously, and then also led to thrombosis of his circumflex, because remember, he didn't have a lot of diseases in his LAD or RCA. And the other hypothesis is that he had rupture plaque in the circumflex, causing thrombosis of the left circumflex, and in addition causing thrombosis in the coronary sinus, causing a very big coronary sinus with a lot of thrombus in it. So basically, this was what the eventual diagnosis was, and the patient went for surgery. He had mitral valve repair, and he was noted to have ruptured tip of the posterior medial papillary muscle. And then this is a picture of the large thrombosed coronary sinus, and with a very aneurysmal left circumflex was visualized. And then they saw that although the venous drainage of the heart was okay, but it was all engorged. They could see a lot of veins because of all the backflow from the thrombus being very large and collateralized. So he did well after postoperatively and was discharged home, and basically this was kind of this is my first case. I still have 10 minutes, so I can go over the second one. Any questions about this particular case?
On this picture, is that his coronary sinus there or circumflex? What is it?
That's the coronary sinus.
That's the coronary sinus.
So you don't do anything with it, you just leave the thrombus?
Yeah, you just leave it, then you put them on anticoagulation. So basically, why would you have spontaneous? I mean, no one knows what to do, the right management, to be honest, because it's rare. And why does spontaneously a coronary sinus can thrombosis when you have some kind of hypercoagulable state? So the next step in his management is to do a hypercoagulable workup, and make sure that he does not have any kind of malignancy that led to spontaneous thrombosis of the coronary sinus, and then and caused also the left circumflex being thrombosed.
I mean, a big aneurysmal section is at risk for the thrombus anyway.
Yeah, so he had a pre-existing AV fistula. He had a pre-existing AV fistula, and now after so many years, what prompted it to clot like that would be something that needs to be further worked up, and he needs to have further evaluation for hypercoagulable workup. So he is going to be on anticoagulation. Yeah, that's the other hypothesis, right? So that the other hypothesis that there was ulcerated plaque that ruptured, he formed thrombus in the circumflex, and then he just extensively thrombosed everything, which could also have happened. We obviously don't have any way to prove one way or the other, but I think definitely should entertain the possibility of a hypercoagulable state for whatever reason. Nick, you're never convinced, but I don't know. You can tell me what.
Sounds like you're saying
Yeah, you've seen a thousand people with a true hypercoagulable state that they don't get coronary sinus.
Well, I mean, I'm.
An AV fistula, it actually is increasing your flow.
Yeah.
It actually reduces the chance of getting thrombus.
Yes.
Right.
So, I mean, I think
That's the answer.
I mean, that's why the vascular surgeons, they sometimes create an AV fistula for venous graft to try to reduce the chance of thrombosis. So.
But if you have a dilated coronary sinus, you would think that there will be areas of stasis, right? Even though if there is
If you
flow.
have an AV fistula,
It's
that's
dilated because of increased flow, not because
right. Yeah.
But I wonder if what happened is that it became dilated and then once the circle occluded,
Mhm.
and now you get this big aneurysm,
Yeah.
coronary sinus,
Yeah.
with a low flow state.
Right. Yeah, I'm not saying one way. I'm not convinced one way or the other. I'm just trying to say that these are hypotheses. One could work around them. You're right. There is a high flow state from the AV fistula, but this is again just what I'm basing on literature. What I found out on that how do these clot. The two hypotheses was this that came up on the several case reports that I read.
The other problem with hypercoagulable workups is they're not valid in the setting of an acute injury, including an MI.
Yeah.
You'll get false positives. And second, they're not valid in the setting of anticoagulation. So once you've already started anticoagulating, it's worthless.
Yeah. So he's not going to have. He didn't have any of the hypercoagulable workup during the hospitalization, but this was a thought that maybe he should have in the long run. Once. No, this was a mitral valve repair. Yeah. So this is just a thought. This is something to keep in the back of mind. I'm not suggesting making any guidelines here, but I'm just saying that this is just a thought. Okay. So I can go over to case number 2.
You got a mitral valve repair? They closed the fistula all the way there?
No, they left it alone. They left it alone. It was all thrombosed.
Did they bypass the surgery?
Yeah, it was all occluded. They left it alone. Yeah.
They bypassed the surgery?
No, because it was all from the top to the bottom. It was occluded. Yeah, and there was scar on the MRI too. Yeah. So there was no point in doing a graft there. Okay, so this is the second case. It's a case of a 67-year-old female with history of hypertension, hyperlipidemia with exertional chest pain, and she had a bicycle stress echo. So I sometimes have issues with identifying the walls. So I thought it might be a good time to review some of those, especially for the first years. So I'm going to pick on Bashar or John. So when you look at a 4-chamber view, which walls are you looking at? And this is just for educational purposes. Don't feel bad or embarrassed or ashamed. I struggle with it still, And I always keep a diagram in front of me, but I always try to make a conscious attempt of naming them in my mind when I'm reading an echo. So this is just so that everyone can learn from all of this. So just throw in what you think it is, and so that I put in a lot of effort putting this together, so I want to make sure that people are learning from it. So this is for your learning. Bashar, which one? 4-chamber view. Which walls do you see?
You see the inferior septal,
Okay.
the basement and apex, and the anterior lateral.
Okay.
That's 4 chamber.
What's 2-chamber?
Would be anterior and inferior.
Good. And what's along in the 3-chamber view?
Anterior septal and inferior lateral.
The anteroseptal and interlateral. Yeah. So the way, just a very stupid way to remember it is, what I do is that I try to, so remember on the 2-chamber view, it's just anterior and inferior. This is anterior, this is inferior. Okay. Basically, what you see towards the outside is always going to be anterior. So this is anterior, and then you always know where the septum is, right? Except for this 2-chamber view, right? So you've identified anterior, you know where the septum is. So this is anterolateral, and this is infroseptum. Because the way the heart is, it's so there are anterior, inferior, lateral, and septal walls. So once you've identified one, you just have to associate the other one with it. So for instance, here the outside wall is always the anterior wall, so that's anterolateral, and this is the septum, so it's infroseptum, just by virtue of elimination. This is anterior, inferior. In the 2-chamber view, you only see the anterior, inferior walls. Here, so John, if you were going by the same virtue, this is septum, right? And this is what? So towards the right side is always going to be your anterior wall, unless if you have an off axis. So this would be infrolateral. This will be anteroseptum. Okay. So this is basically how you see these are the walls. And then in basically in this view, I always mark the anterior and inferior first. So this is anterior, inferior, then septum and lateral. And then by virtue of this, you can say this is infrolateral, this is anterolateral, this is anteroseptum, and this is infroseptum. And this is the same for whether you're looking at the PAP, whether you're looking at the level of the mitral valve, and then you just have the anterior, inferior, lateral, septal at the level of the apex. So now the distribution. So Bashar, which area is distributed by what? You have a color combination to go by. So you already told me that where. So what area is supplied by which area? Which vessel?
The anterior and anterior lateral is supplied by
Right. So you here see this is basically purely your anterior wall, and a lot of the apex is supplied by the LAD. And also your anteroseptal wall, right? Whereas wherever you and what about so to simplify it,
and the inferior and anterior septal by the RCA.
Exactly. So to simplify it, just clear out what LAD and inferior are. Get those out of the way, and then circ will come later, because circ doesn't. If you look at this diagram that's on the chamber quantification guideline, circ is pink alone, and there is no wall here that the circ solely supplies. So it always shares a territory with another vessel. So if you know the inferior and the anterior, then the LAD and the RCA, then the remaining ones are ones that either the RCA or the LAD share with the circ. I guess that's kind of, I don't know if it's a twisted way to remember it, but it's kind of something to start with if you're trying to figure out which walls are supplied by which arteries. So this is the bicycle stress echo of that lady. Let me just loop this. I have looped it, but I don't know. Okay. Okay. So what I'm going to just let you look at it for like 2 minutes and then move on to the next one. Any areas that you see that are abnormal? These are hard, of course. I mean, we all struggle with them. They're not easy. I guess I
The inferior septal.
okay, I'll let you look at this one. I guess it's the best on this view.
Inferior septal.
Dr. Corman, do you want to comment on this?
Sure. So basically, when you're looking at these, one of the easiest things is to look and see, the very first thing that I do is I look and see, is the cavity size getting smaller? If the cavity size isn't getting smaller at peak stress, you know that there's a area of ischemia. So when you look at 75 compared to rest, you can see that the cavity is not getting smaller. So then you have to go back and you look at the thickening of each and every single wall. When I look at the inferior septum at peak, I can really see it thickening really quite nicely. That whole septum is thickening really quite nicely. So that's probably the best wall. So I'm like, it's not that wall.
It's the anterior lateral, right?
So then you go to the lateral and you can see the basal segments of that lateral wall are thickening also quite nicely.
But not that.
There's a hinge point right at the mid-lateral wall, all the way up to the apex when you compare it to all the other views.
Good. So I guess it's all about training our eyes, but this was in the LAD territory. This patient had an angiogram, but this is a multi-modality imaging conference. So he also underwent a CT scan.
Oh, you gotta show them the two-chamber.
Yeah, sorry. Okay, let me just show.
You gotta pick on somebody else on the two-chamber.
John, since you're the only other first year here.
I'm glad that you think that second years know this.
Yeah, I'll tell you.
No, I want to survive in this program for another year, so I'm not going to pick on my own
The
kin.
two-chamber is also not completely normal, and you've got to use that same sort of method that we did on the four-chamber to try and figure out why the
Sorry.
cavity isn't getting smaller.
The anterior,
Still
like,
the
wall
anterior,
down
apical
towards the
anterior.
apex.
So remember, in the two-chamber view, the only two walls that you're basically looking at are the anterior and inferior wall, right? And here, what you're basically seeing is the inferior wall comes in, as Dr. Colmer mentioned, that it thickens at peak stress, but the anterior wall kind of lags behind.
Again, from the mid-segment up to the apex. Can you see that? Where that anterior wall is lagging. So now you can go to your next slide. So you've got the anterior, so you basically, before she goes there, so you've got the apex, the lateral apex, the mid-lateral wall, and you've got the anterior apex and the mid-anterior wall. What disease do you think this patient has?
Which artery? And we just went over this. Which are? Don't disappoint me. Tell me the answer.
You get the LAD, right?
Yeah, that's right. Yeah.
LAD's one. Well, it wouldn't be distal because it's taken down your mid-anterior wall and your apex.
Yeah.
So it's going to be at least mid, and then what other artery? Because it's taken down your lateral wall too. Circ. Yeah.
So basically, this patient had a cardiac CT performed, and they had an anomalous. Jeff, since you're on CT, what do you think?
It's an anomalous.
Originating from the right coronary cusp. So basically, and then the course was also malignant, and I guess if Jeff, you could talk about what a malignant course is for.
Yeah, I mean, it's traveling in between that looks like in the wall, but traveling between the PA and the
aorta.
inferior,
Yeah.
posterior to the PA,
Yeah.
I guess.
So I mean, I don't have the portal here, so we could have tried to swivel in and out of it. But this was a malignant course, and then the patient underwent bypass surgery, and basically had resolution of her symptoms after that. She's a clinic patient of Dr. Kumar. So I think that's it.
She was very young when she had it.
Yeah, she was. This was in 2006. So now she's what? She's
So she didn't have
67.
any obstructive disease. It was just based off the.
Yeah. Yeah.
It's interesting how that doesn't. I mean, you'd think that that's been there her entire life. Why it takes until she's 60 to present?
Well, the great vessel
I guess.
Mhm.
Yeah, maybe something. Thank you.
All right.
Great job.
Thank you.